Hey, it's Elge for Simple Lines Anatomy. In this video, we're going to be doing some structural proportional analysis, some anatomical assessment, if you will, on a real person, in fact, not just a model we've drawn up, as we so often do. So this was a person who approached us through Instagram and said, I am having back pain, I'm having some body problems. I wonder if you could maybe tell me why that's the case. And we're always happy to do this when possible, particularly if it's an interesting case, because it makes a good explanation of how the body works physically, functionally, and at the same time, it generates some good content for our page. We do have to say, as a disclaimer, we are not doctors, nor is this to be taken as medical advice for any reason. There will be no actual medical diagnosis going on, some structural assessments, maybe some proportional diagnostics happening, but this is really for both educational and I would say artistic purposes. We hope at the end of this, this particular follower can take this write up, this workup, and take it to a properly trained manual therapist who will really make their own decisions about what to do, but use it perhaps as a secondary opinion, just to say these are the things we see happening in the anatomy, and they're worth looking at. So, anyways, without further ado, click. So, this is the person that came to us a short time ago about having us look at them. Now, they sent us a bunch of different pictures on our request, and they gave us permission to post this, of course, and we had to work with different angles at a great distance because we'll never meet this person more than likely, and so we can't do any hands-on assessment. So this is the first of two videos. In this first one, I'll be explaining interesting points, but as well how you go about doing this kind of assessment, like a picture-based assessment, because it is limited. It is nothing compared to a real-life hands-on assessment. Just to show you a few of the different views, you get some different angles and you will see different things. To us, they're plainly obvious as to what's happening, but it's not going to be for everybody, of course. We have a list of symptoms too. We're going to reveal those at the end, and then we'll continue on with that in the second video, and you can see how the structures can go into creating some of the symptomatology. Sometimes, not always, it's not absolute, but you can see how they're related anyways. So, in this case, we were immediately drawn to a single focal point. These are my little notes here to keep me going, but right away I see that, just boom, right off the bat. First impressions are important, and the reason we say that is because it looks to be that there's just a little bit of a bump here. Something looks like it's sticking out. It's kind of coming back at us, if you will. It's coming towards the screen, and then we've got some discoloration of the tissue here, and then the spines basically above and below it seem to be in different shapes. Now that was just boom, first impression, so something was wrong right there. Now that's nothing. That is literally nothing. That's just a first impression. It means so little, but we're gonna go through and show you how there actually is something there based on different viewpoints and different motion positions. Like we caught some things in motion, basically. So let's throw in a few simple lines. Hey, I didn't even plan on doing that. Okay, let's throw in a few lines just to try and make sense of the thing. So I'm going to throw one right in the middle here. You can see my cursor going down, and I'm going to just fade that a bit so we can see the person. We're more interested in the person. So vertically, take a quick look and see, do you see this person sitting more to the left or more to the right? And I'm going to say right off the bat, I see more on this. This is the right side over here. Wrong tool. There we go. More on the right side over here. So more bulk there than over here. So we have to say, okay, if I've got more sitting on that right side, I want to pay attention. So where is the left? Where's the proportion of the left? They're unbalanced is what we're trying to say. Definitely we see an imbalance right off the bat. And then we can start to see it in the pelvis as we work our way down too, because we've got less on the left, maybe more fullness and higher up on the right, but we'll get into that more specifically. So we'll throw into just a couple more lines. These are, again, these are just easy to look at kind of things. If I just put my cursor here, just going to put it on, the pointy bit of the shoulder, which should be the acromion. Oops, did not do that right. Okay, pointy bit of the acromion. And I'll put it on the other pointy bit, which I'm hoping is the acromion. We can kind of see that even though, I'll close right up on that, even though it's not a huge difference, it's slightly higher on the right. Again, that's nothing yet, but it's showing me imbalance. If I do about the same thing to the hips, look, if I throw this in here, that's about, I'm guessing, like just based on what I'm saying, I'm guessing that's the iliac crest, and then that's the iliac crest, because I say that because it's got a little bit of a lipping, this area right here. If I can match left and right, it's also a little bit higher on the right. So we have something going on. The balance isn't there. You would actually hope in a more normal spine to see the opposite curves some of the time. Anyways, it's hard to say. So let me get rid of that. So right off the bat, we're seeing some imbalances showing up. So that's like shoulder versus hip stuff. Those are easy things to do. And you should be able to do this just visually, like me drawing the lines out. It's cool, it's whatever. But it's so unnecessary if you're seeing patients regularly. But this is a good introduction into what it takes to do this kind of thing. This is a summation of these elements. Also, I can't physically feel it, so I gotta rely on some other tools here. So let's look at where we think the curves are now as well. Make a nice light green for that. Go up a little bit in opacity. There we go. All right. So notice this side of the neck versus this side of the neck. Right off the bat, we've got a little bit of that going on and a fullness. So I'm going to say pretty sure that we've got a neck that is more this way. It's running that way. So it's pushed to the side. So it's pushed to this side. We call that a translation of the neck, and we'd call it like a left side bend because it's short on the left. It's bent to the left, and then the AA would be approximately right there. And then looking down, I'll catch the midpoints in just a second. Looking down, because we have got more of a fullness to this side, I'm guessing, and this is just a guess, I'm guessing we've got also a left side bend going on here, because if the rib cage is attached to the thoracic spine, and of course it is, rib cage is back, tends to be, unless there's a very extreme traumatic event, tends to be that the rib cage follows the bend, or it follows it into rotation. So because it's rotation on a vertical axis, if the thoracic spine is bent to the left, I should see a right rotation. The right side's coming back at us, you could say, in the thorax. The proper terminology is to base it off actually the vertebral body. So in this case, the vertebral body would in fact be the one facing in that direction. So if that's the vertebral body, it's pointed that way, as we've explained in other videos. Okay, now lumbar spine. I'm gonna guess, now here's the thing, lumbar spine doesn't really side bend too much. It's got a little bit L5S1, and I'm seeing this kind of a curve here. It's because I'm seeing those anonymous, those ilia on either side. Drawing them too big here. There we go. I'm seeing them like that. Again, we've got one side high, by a bit, but it's enough. One side relatively low, which, if we start low, like comparing these curves, we can sort of figure out the points. So L5S1, I'm going to say L5 is side bent to the left, maybe rotated right. That would be traditionally it. I don't know for sure yet. I'm going to consult a few other things. But anyways, then we have to make these transition points make sense, because this is where the big twisty stuff happens. Quite literally, the big twisty stuff, because you get an end of the rib cage right about there at 11 and 12. Yeah, give or take there. And so it goes from solid bone to floating bone. We've got the lumbar spine in this region, and there's less stuff there. Let's say it's less reinforced by the cage. So I'm going to say this part, we get a quick hard side bend, and then it goes in to that curvature there, just based on what I'm seeing. And then again, the same thing through here. So it should be curving back and forth, just to balance this out. So in a way, it is balanced. If you look at it, it's not great, but it is balanced. And that means mechanically, he's still able to stand up, and he's not like sitting all the way over here. He's not just bent to the side all the time. If we didn't have these opposite curves, his head wouldn't be straight. It would look weird. It would be confusing to view. So that's a start. Understand that I'm exaggerating these curves pretty heavily. If it was torqued up exactly like this in this exact pattern, that would be bad. This would be more of a scoliotic, we'd be heading towards a surgical case, but that's not what this guy has. He's somewhat balanced. I'm teasing out the curves basically. And that's just the start of this. Okay, so we have to mention too, I'm just going to pull that away, get rid of that, throw in one more layer. Look at where the scapula are. You can't see anything on this side, but you see this edge right here, this kind of darker edge in this region? That's the scapula right there. It's not normally this far off, so it is definitely sticking out that way. It's being essentially pulled out, I'm going to say, pulled out by a short pec. At some point, pec major, minor, something's doing that to it. So we've got a protraction there and an elevation. It would also explain some of the bulkiness of the trapezius muscle too, why it's so elevated in this region. So that's looking good. Now it doesn't make sense why we've got, again, the bulkiness here yet, but we'll figure that out hopefully a little bit later and explain what's going on. So this has come far enough around that it's actually created an edge. So the fact that we can see the edge means it's protracted enough to have winged just slightly. Not like a medical problem kind of wing, but just enough that it's being pulled off. The surface is uneven. And it probably has to do with the fact, just throwing this other layer back up, probably has to do with the fact that we likely have a posterior rib cage in this area. So again, we said this rib cage through here. We'll get rid of that. Hold on. Make that cleaner. So this rib cage here was coming back, and it's pushing into that scapula. Okay, that's not bad. So, talked about that. And now, this is it's kind of a throwaway thing. Do not let anything be determined based on this. But look at the difference in the amount of space we have through here. Let me just adjust my pen size a little bit. But look at the difference in space we have here. If I just fill it in, again, this is just a silly little thing you can do to understand imbalance. There we go. So we've got a bigger space on the right than we do the left. And so that tells us something about the way the arms and the shoulder girdle is sitting. So that would be approximately where the head of the humerus is. And then there's the arm carriage. And then that's where on the other side, a little bit lower. There we go. Arm carriage is on that side. There's the ulna. And so we're going to say he's doing something like that. That would be my guess. I'm gonna say give or take. These are, again, not perfect ways of assessing the body. They're nothing absolute has been determined yet. Just ways of looking at things so far. So let me get rid of a few of these things. We'll get rid of that and that and that, and let's look at a slight 45-degree turn here. So this just changes the angle because we want to see a bit more of the shoulders, really. That's what we were interested in at first, but when we started looking down, it started to make a lot more sense. This is more of a full body problem. So look at this curve here. We're not looking straight from the side. When we look straight from the side, you're gonna really enjoy that. Oop, wrong layer. There we go. New layer. Constant problem. All right, so let's look at this big curve. This almost looks like, I don't know, like a lemon slice or something, Ethan Becker over here. So it's got this big curve. That's most definitely going on. And so normally the thoracic curve shouldn't extend too far up into the neck. Now he's got his head bent forward, like it's coming down a little bit, which will flex this. That's supposed to do that. But it's a bit too much, especially, see how much this part sticks out here? That's not just C7, that's not just the vertebra prominens. That is partially a T1, T2 flexion. As far as I can tell, it shouldn't really stick that far back. It's pointing out. And then, as we start to look into this thorax, the reason why it's got this shape going on is because the flexion curve, which should really be ending about there and starting to transition back into a normal lumbar curve, is actually extended down probably into L1, L2, and is shooting back, I'd say at about L3, 4, and then like back into a flexion kind of thing. That'd be my guess. Again, nothing absolute. I can't touch it, so it's hard to say. So, but just look at the big thoracic flexion. It also means the ribs in this way So if the whole thing is flexed, it means anteriorly on the front side, he's dropped down a bit. It means all those ribs are kind of angled down a bit too. They get drawn along with it. And this is nothing. I'm not too worried about that part of it. You know, there's bigger fish to fry here, if you will. But that being said, it will need to be addressed. Again, we're hoping this person sees a manual therapist of some kind, exercise-based therapy, gets the help they really need. And then that way they can address these sorts of things. They'll catch it, I'm sure. All right. So now let's just skip down a bit. See if you can see what we see. The feet are collapsed. So we've got this angle here going on. We've got that. But that's telling us it's gone all the way to the bottom. So it's the aberrant forces travel all the way down. Let's look a little higher up and maybe guess as to why. So feels like just from this angle, because of this curve here, and because of what we're seeing and what we're going to see in other views, the pelvis is kind of come anterior. It's kind of come forward. So we call that an anterior pelvic tilt. And so the innominate, the ilium, ischium, all that, is forward. So if I was to draw it just from the side, you know, there's your ilium up top, ischium and pubis, and there's your hip joint. Well, it'll rotate basically forward like that as a whole, both sides of the pelvis. And that seems to be shown in here. As well, we're pretty sure we've got some kind of a collapse of the knees. The knee on this side, I mean, you can kind of clearly see it dropped in. I'm pretty sure this one is as well. It's not showing it as well. But that would then cause the tibia to go this way, tibia, fibula, and then that puts the ankle in such a position that it puts pressure more on the inside because more of the weight is now medial. So the body's weight is dropping down like that, which tends to push out the arch, if you will. Okay, so that's good. We're going to look at it at a different angle too, and we're going to see approximately the same thing. This is a front view, shows this pretty well. So we will circle back to that. All right, now a side view with a bend, because we wanted to, and I mean, hopefully you can see this almost immediately. If you can't, don't worry about it. I'm going to illustrate it all. So look at the curve here. We wanted to see what it did when it moved. So we had the person, pardon me. They're not a patient. We had the person, one of our followers who requested this, bend over into what you call a flex position, about as far as they could go, just comfortably, what was normal to them. It's very important that you could get them to do this, what they feel is normal, so you don't give them a chance to hide, because, you know, it's kind of like being at the dentist. Everybody will try and move in a fantastic way in hopes that they can trick you into thinking they're healthier for some reason. They're in your office, so I don't know I don't know why. They're there for a reason. Okay, so look at that. Oh, yeah, again, always with that. Okay, so look at that point right here. Look how high that is compared to everything else. You know, you alone, if you started at that, you could be like, oh yeah, that's not supposed to be like that. We've got a flat part here and then another relatively flat part here, ultimately leading to a little bit of a curve, of course. You know, we've got kind of this thing going on, but flat, flat. So extension, extension, big flexion. So the flat parts, those are extension by definition. The curved part here is a flexion by comparison. But it's a big one. It's quite excessive. It's like it's being pushed back. It's so big. It's not. It's more being pulled into this position based on the anterior stuff. But let's not get ahead of ourselves. So look at that point. So there's some kind of a flexion in this case. Some kind of a flexion here. Let me get a slightly bigger pen. There we go. Not too big. 15. That'll do. Okay. There we go. Flexion for sure. And that means above and below, just based on what we're seeing, has to be an extension. There you go, extension, extension. Now, we know to create that flexion, or at least sustain it, there has to be some kind of a shortening of myofascial tissue somewhere. There has to be a shortening of something. It's kind of like a bowstring. If you bend a bow, there's going to be a string somewhere tied on either end to hold it in that, and that's basically what we got here. So in this case, fairly obviously, it would have to be the muscles on the anterior side here that are short. Whether they contracted and got that way, or the spinal joints got put in that position, maybe by a forcible movement, and they rested in that position for too long, the anterior part is holding it there now. It's been long enough. We'll get into the case history again in the next video. That'll make sense of it. But look what it also shows. There is something going on. I'm going to get rid of these lines too. There is something most definitely going on here as well. It's not as prominent, but this curvature through the low back is a little bit odd. I'm going to draw it off the body, but very, very flat here. Little bit of a dip right there, back into that flat thoracic area. So this kind of a bend in here, not really all that normal. You don't see that little bit of a, it's not a huge bump, but it's a bit of a bump in this case. And it's worth, you know, again, it's something that's just worth investigating because it's outside of the normal. So there's something going on with that lumbar spine for sure. It is flattened and it's definitely flexed. I'd say more at the top and bottom than anything, not so much in the middle. That seems to, in this case, be more hyperextended than anything. But we'll address that a little bit later. Another thing worth looking at, yeah, we've got probably too much extension through the upper part of the cervical spine. That's the neck for the uninitiated. That's the neck. So looking back, I'll just pop up one of our previous pictures because we were looking at that part. We said the thoracic spine was going into too much flexion through here. Well, it means that chances are, if he wanted to keep his head up straight, the upper part, just the upper few, would have to go into a big extension right about there just to make this whole thing work. Otherwise, he would be looking at the ground all the time. That makes no sense. And that doesn't seem to be happening. Anyways, back to where we were. So, the cervical spine, though flexed at the bottom, probably very extended at the top. Okay, another view. So, we had one more kind of 45-degree view of this thoracic spine. So you can see again, you can see the rounding through the shoulders here. I don't know how many times I'm going to do that, but apparently a lot. You can see the rounding through the shoulders here. That's fine. We had a view of that. That's almost not in any question anymore. We know there's a big flexion there, and that's going to have to be dealt with at some point. But looking at this angle now, we've got a better view at this point. So this bit of a funny spot in there, that's really worth looking at. Because again, we've got the big curve here, and we've got, now we can even see it worse, a big flexion curve here. So we've got a flexion probably L5S1. We've probably got a flexion that's running from about T12, the 12th thoracic, all the way down into L1, L2 sort of region, at least. And again, I'm going to say more than likely for him to just be able to stand up straight, very much hyperextend L3, L4, just to manage this whole position. And that's just how it has to be. You know, it could be that he's all flexed, but realistically, we wouldn't be seeing, just, you know, going back to what we had before, get rid of that, going back to what we had before, we wouldn't be seeing this kind of a curvature through here, this kind of a thing. This big, steep curve simply could not allow for full flexion all the way down. Just like a big swoop like that. That doesn't make any sense. You know, you'd know that. He'd have lost quite a bit of height had that been the case. A little young for that, more than likely. So looking at this angle, we've definitely got our flexions they're a little more teased out. We can kind of see where it's short. And that makes sense. And based on the other things we've seen so far, it matches nicely. But another little point here that's worth looking at is not a huge, now this guy's not a big guy, but if you look at the erector spinae, let me get rid of some of this eraser tool, that's always useful. There we go, close enough. Okay, if you look at the erector spinae, again, not a huge guy, but big enough that these erectors are larger. So these erector masses on either side are bigger than you would expect them to be for a guy this size. And maybe there's some working out, but you don't see it in the rest of the spine. You don't see it in the thorax. You don't really see it in the cervical spine. It's disproportionate. So you know that these erectors are this big because they're having to contract constantly and sort of tirelessly. It's excessive work. And so that's a good thing to know, because it means they're trying to hold him up all the time, and they're doing a good job. It's just that they're ultimately failing because time and pressure will eventually win. So this is something you got to understand. Okay, now one more thing. We wanted to kind of define something. You know, finding the angle to do this is very difficult because we've tried to do it in the past. Other posts, we didn't do it in video form, but we did them in just like written picture form, more slides. And we couldn't yet figure out a way to figure out where the sacrum is, or at least to show it to a wider audience and make it very obvious. But having this curve like that, we would say the sacrum is definitely doing some kind of a backwards position kind of thing. It's stuck, more than likely counter-nutated to say the least, and there's, you know, most definitely a twist in there that's torquing it in some funny direction. So it is a posterior sacrum, and that's on a transverse axis. So the axis is running through. This is getting real complicated. There we go. Transverse is running through like that. So the sacrum is most likely posterior, just based on that general overall flexion. Even if it's hyperextended L3L4, it's tipped back just on the way he's sitting there. And this is going to factor in when we start to account for the legs. Again, you can kind of see the arch is not great, but it's also not terrible in this position. So he's bending over. There's probably more to that, but we're going to leave that out. So get rid of that. So up one more view. Okay, now it starts to get very obvious, I feel, when you look at this image. What you could say is some problems area in the lower body. So we had an unlevel pelvis previously. So let me just pull up, you know, one of the other pictures, the first picture we started with. When we saw this picture, we definitely had an unleveling here. And again, there we go. Had an unleveling here for sure, but it's more blatantly obvious, I feel, as we start to look at the front view, the anterior view. So this is the hips and pelvis and knees, and so we can see again that there's, I'm not even going to say up or down, I'm not too worried about this case, but you see a bit of a side shift. There's a bit more of a, oh boy, there's a bit more of a fullness through there, like that, just a little bit. It's noticeable, whereas this side's a little straighter, this side's got a nicer curve. So it's showing me something is kind of pushed to the side, if you will. It's being held to the side really from above down, but you know, don't worry about that. That's for the future. Okay, so something's going on with that, and so he's a little more centered on the left side. And now if you go, just skip to the bottom, if you see the left side, I feel like this side's a little more turned like that, turned out. That would be an outward turn of the foot. And the arch is a little bit more collapsed. Not a ton, it's not huge. So it's showing us something's going on with that left side for sure. That's the area of collapse. And if we look at the legs, the angulations of the legs, again, reinforce what we said before. I just feel this is a better view. So the knees seem to be, again, fuller on this side, which means the angle is inward a bit. This is not like a full knock knee kind of thing, but it's enough to be an issue. Shouldn't really be having this. And then definitely, if we just put a nice kind of, oh, didn't mean to do that. If we put a nice cross line through here, let me just throw this in. There we go. Hopefully you can see now, if we angle down, we'll just draw it out. If we angle from knee between the ankle and then knee between the ankle, they're sticking out just a little bit. If I was to exaggerate greatly, I'd go like that. This is how I see it in my head when I do this stuff, because ultimately that's where the weight lands, because the weight tends to come on the inside and then it drops down like that. I'm getting ahead of myself here. So anyways, the tibia is kind of coming down like that, out to the side and a little bit out to the side. And again, this puts pressure on that inside part of the foot. And that inside part of the foot is a muscular arch, and it doesn't have the endurance to sustain that pressure indefinitely. What that muscular arch is made for is expanding and recoiling with gait, with walking or running. And so that means it's a temporary thing. It's an on and off thing because it has to snap back. The outside edge is a bit better for weight bearing, but he's clearly not doing that. So we know we have a few problems going on here into the lower body. Okay, I'm going to finish, pop up the list of symptoms that he explained to us. And we're going to go over that. We're going to start with those in the next video. And then we will finish by explaining. We'll finish this. We'll complete the second video by explaining what we saw in the visual, proportional views, why those relate to what he was experiencing, which is a very roundabout way to do it, but it will make sense, I hope.